Now, okay, apologies for that. Apparently you can't hit record while you're sharing your screen. So we learn something new every day. All right, so I'm going to give a quick overview of what we're doing in Washington State. I know many of you are familiar with this, so this will just be very brief, and then we'll move on to our speakers. So really quick, just to level set, for those of you who are kind of not familiar with shared decision making, we at the Healthcare Authority, we use the National Learning Consortium definition that shared decision making is a process in which clinicians and patients work together to make decisions and select tests, treatments, and care plans based on clinical evidence that balances risks and expected outcomes with patient preferences and values. One thing I do want to point out is that we use shared decision making for preference sensitive conditions when there's more than one, quote, right answer, or there's a high uncertainty about all options. An example of this is like joint replacement or spine surgery. What this is not is vaccinations, because that's clinically appropriate that we do that we vaccinate our children. So in these settings, for these different types of examples, shared decision making can help the patient make a decision that's based upon their values and preferences. So why is it important? Well, we found there's been a lot of research around shared decision making and the use of it. So we found that using shared decision making can not only improve the patient experience, it improves health outcomes, reduces variation in health disparities, and increases equity. There's a fascinating study that's been done on males who are, depending upon your race, some are have more tendency to get a total joint replacement surgery than others. And so what it kind of does is it equalizes that variation. It also improves appropriateness of utilization and spending, as well as supports value-based care and population health strategies. And, you know, mostly shared decision-making really is a key element of patient-centered care. And again, I mentioned most studies involve the use of patient decision aids to support high quality shared decision making. So it's not just about shared decision making, it's also about the use of using patient decision aids to support shared decision making in practice. So if you're not familiar, patient decision aids, they're tools. They're used by providers during shared decision making to engage the patients in those decisions by providing them with balanced information, non-biased information that helps them make an informed choice. And so they come in many different forms. There's written documents, there's links to interactive websites, there's videos, and there's visual aids. So those are just some examples. And there's also been studies done, and there's a link to one of the most famous studies below, a Cochrane study about how decision aids increase knowledge of options. They provide more accurate risk perception, lower conflict about decisions. They help patients make choices that are more consistent with values. There's greater participation in decision making, and at the end of the day, fewer patients choose major surgery. So I won't walk through all of this, but the history of shared decision making in Washington, especially at the Healthcare Authority, goes back to the mid-2000s. There was a study done by Jack Wenberg of the Dartmouth Institute back in the early 2000s that looked at variation of care across states. And he came out to Washington State and presented to healthcare leaders and our government leaders in Washington State during that time, and pointed out that, you know, we had a lot of variation in care depending upon where you live. An example of that is if you live in Port Townsend, for example, you're more likely to receive certain services such as joint replacement than if you lived in Yakima. And so the solution to that is to think about how we can use shared decision-making to reduce that variation. And so at that time, there was a multi-provider shared decision-making collaborative that took place, as well as law that was implemented that provides liability protections for providers under an informed consent rule that says if providers use shared decision-making or use certified patient decision aids during shared decision-making and document that in the chart, that they have a lower burden of proof should something occur during that procedure. So patients who engage in shared decision-making and sign that they've been adequately informed, the burden of proof is higher for them to say that they were not adequately informed. Another piece is the BRE Collaborative. The BRE Collaborative, many of you know what that is, so I won't go into detail too much. That was established to focus on unwarranted variation and promote the use of evidence-based improvement strategies. And lastly, in 2012, there was a law that gave the state healthcare authority medical director authorization to certify or recognize certifying entities meeting specific criteria for decision aids. So overall, the goal was appropriate utilization based on patient preferences rather than decreased utilization. And so the evidence suggests that shared decision-making does increase that overutilization, but helps correct underutilization, as I mentioned before. And here's a reference to the study that I mentioned about the total knee replacement. So lastly, the healthcare authority specifically role is we are the only certifying body of patient decision aids in the country. We were hoping that there would be a national organization to pick this up, but that hasn't occurred yet. We promote the use of shared decision-making and the use of certified decision aids in our role as purchasers. We cover 2.1 million Medicaid lives and 400 PEB lives, public employee benefits, as well as 300K school employee benefits. And so we also provide training and support to providers to do shared decision-making. And what I really wanted to point out is, so we've collaborated with the BRE Collaborative on developing and disseminating recommendations around shared decision-making for implementation into practice. And I've got a link for those. Although the BRE does include shared decision-making across a lot of their topics, we did have one specific work group that focused on how to do shared decision-making well. And lastly, we continue to convene statewide discussions around spreading the use of shared decision-making and sustaining it in practice. So here's a link to the resources I mentioned. I won't go into detail about these. You'll have the slides. And now I'm going to turn it over to David Arterburn to introduce our first speaker. Thank you, David.
Thank you, Laura. It's a pleasure to be here today. Appreciate the opportunity to speak with you about our shared decision-making work. And this work's been funded by the Patient-Centered Outcomes Research Institute, or PCORI. And throughout that journey, I've had the great pleasure of partnering with Dr. Neely Williams. Neely has had the unique patient perspective as a patient co-principal investigator for our project. And that was something that I had not experienced before. And she helped us learn how a patient co-principal investigator can function within the context of a study, and has been able to work with us throughout the journey from the inception of a research idea across a large national network of through the PCORNet network, through the whole conducting of a research study, comparative effectiveness research study, and now into the implementation of that science into clinical practice. So she provides a unique perspective on the patient role across the journey of developing research and implementing it into practice. So Dr. Williams, appreciate your time and really excited to hear from you today. And we'll be turning it over to you at this point to share your perspective and journey.
Good morning, everyone. Thank you all for having me and allowing me, David, this opportunity to share with this wonderful group of people. It's been just lovely, just even hearing the conversations as we prepared for this. I have had the opportunity to work with David along this journey, and we have many lessons learned. And we are just grateful for the lessons that have been learned. And we believe in the process we've been able to help the science of research as it relates to bariatric surgery and those who are impacted by it, as well as develop some techniques and processes that will help with the decision-making process as this moves further along. But let me tell you a bit about, let's show my first slide here. It's a bit about the ProCoronet bariatric study. The largest study of 3 most common used weight loss procedures in the US: the adjustable gastric band, known as the lap band or band, and the Roux-en-Y gastric bypass, often referred to as the bypass, and the sleeve gastrectomy, which is usually referred to just as the sleeve. Now, these are very, very much used procedures for the bariatric procedures. We looked at how each procedure compared to the other for 2 things: weight loss and regain, and improvement in diabetes, adverse events over up to a 5-year period. Why was this topic important? Using the bariatric surgery we knew the use of bariatric surgery was expanding considerably. So sleeve gastrectomy procedure had been used increasingly over the past decade, in spite of a lack of data that compared the effectiveness to other procedures. And it just felt like a natural to move it in this regard. And when I was brought on at the very beginning of this process as we began to think about it. And let me give you a little bit about me. As stated, I'm Neely Williams. I'm a patient partner researcher or non-scientist, a ordained minister in the Christian faith, and I'm a widow, a mother, and a great-grandmother, which I'm very proud of. And I also work as a community engagement strategist. I seek to help folks in my community who are doing research to connect with the community and help to provide and craft a language that can allow for greater communication across spectrums of values and thoughts and ideas, experience, and communities. I'm passionate. I am passion and mission driven. As a child of the 50s and 60s, a sharecropper's daughter, a product of a segregated school system in the South, developed a deep, heartfelt desire to make a difference. And my personal work ethic was born from that experience of working on a farm for very long days in the heat of the day. I became passionate and mission driven as I learned through this process as a child, being guided by my parents. I served as a foundation of the work for my work ethic today. I want to move to the next slide. And I'm sorry, I don't think I'm telling the young lady to move with me, but I hope she's been able to kind of follow me. We're on my bariatric surgery journey. Well, I certainly had an interesting, I think, to most an interesting process, because I struggled with weight for many, many years of my life. I lived for more than 30 years, over 300 pounds. I had insurance issues at various stages of the game. I was born in that era when they talked about it was stomach stapling, and everybody who had it died, and there was just a lot of things that was going on that was not positive and certainly not informative to the process. And so with the non-coverage for the surgery, that became an issue at the point where I realized and started to do the research and figure out it was a helpful procedure, would be a helpful procedure for me. But I made that decision, and opportunity provided itself that I was able to secure that surgery with my insurance became available for me to get the coverage that I needed. And then the long-term follow-up is very important was very important for me. This came with building long-term relationship with service providers, nutritionists, and health medical assistants, and folks who take over after the process has been completed, but they are still vital and very important to the outcome of the success of the surgery. And I think we've been able to incorporate some of this into the decision-making process so that people understand that It's not a quick fix. It's not something that you can just turn on a switch and there it is. It's all done and you just go on about business as usual. But it's a recalibrating, a re-establishment of what your life values are and a new relationship to food in general. So our next slide is my research work focus. My experience led me to the CoreNet, a network of dedicated to placing patients center in the research process. And of course, that began with my relationship to PCORE. It was the actual one who established the PCORE network of networks is what it's referred to. And the bariatric study, the PBS, was among its first large-scale research projects, a study that was actually done in 18 months. And no such thing had been done with such a large number of patients as this ever before. And it was a very daunting task. But the intricate parts of it and how engagement happened is just more than we could ever tell you in this moment in time, but it can happen, it has happened, and now we are continuing to teach the lessons that we learned. And the next slide is my roadmap to becoming a patient PI for the PBS. As a patient PI, I work to develop solutions and to contribute to the decision-making process. As I previously stated, I'm a minister, a community advocate, and a community organizer. So I came into this process with many skills that were needed to serve in this position. I have a case manager and a pastoral counselor for groups of folks across my community who was devastated by health events in their lives. And certainly research was a part of the dynamics of what they were going through, whether it's HIV AIDS patients or people who were impacted by violence or folks who were in more states than we can name, but they certainly were impacted. And these are the things that I had the opportunity to work with. And I served in numerous capacities across the city of Nashville as an advocate and as a person who served underserved populations. Our next slide is how did I and other patient stakeholders contribute to this PBS research? Well, for CoreNet, the obesity task force was 2014, and I happened to be one of the patients that got asked to participate in this working group where we generated an obesity research topic ideas. Ideas was prioritized, the resulting into PCORE funding announcement for 2 topics, weight loss surgery and the effects of antibiotics on weight loss in children. And I was able to work with the weight loss surgery. The task force members included patients, surgeons, and other researchers. And there was a lot of language being spoken at that time that was not familiar to me, but I was catching the gist of the conversation and understood that this is how do we help funders understand that this is a major topic that needs to be addressed around the health of a nation, and recognizing that we are calling patients to be centered in this work, and that we wanted to impact the lives of those that was most impacted by the problems, the health disparities that exist in our countries. So we requested PBS researchers do comparatizations of all the bariatric procedures, not just the bypass and the sleeve, which would put the band back into the process. And then we requested researchers to interview bariatric surgeons as part of the qualitative research, not just conduct patient-focused work groups and assessing, getting feedback from patients, but we wanted to understand how the researchers, surgeons were also impacted by these. These activities were carried out with stakeholder input and data collection and interpretation. So we stayed very central to the game. The stakeholders helped with dissemination, creating study brochures for professional societies, creating and testing smart patient toolkits for clinical data and the patient-powered research networks, the PPRNs who were part of the process at that time, developed lay summaries for main study findings, making sure that information was communicated out in communication in journals and papers that would reach the masses and not just to a scientific audience. Created author guidelines to be used by all stakeholder audiences and helping the patient partners understand their contribution And not only them, but also researchers too, to partner on the development of 2 different bariatric surgery decision aids, and served on a shared decision-making implementation team for the Kaiser Permanente and the University of Pittsburgh Medical Center, which we still are doing work with today. We were impacted greatly by the COVID, as many and much research was, but we continue to stay in the game, and we continue to do the work that was needed to be done at the rate that we could. And now we are having opportunity to move that work forward. And we're grateful to Dr. Otterburn for really guiding us and leading us in this process. The next slide is my perspectives of lessons learned as a patient PI. These are the things that I felt were very important for us to share with you today, and we shared them across the country numerous times, is to create a collaborative environment where all stakeholders are empowered to share their perspectives and expertise, including patient non-science or patient partners. We really want to create that environment, and that within itself takes some work so that you are able to make the people feel comfortable in their environment, their settings, listen to their concerns and questions, identify their value systems and things that's important to them as we begin to build this relationship. Then we want to enhance the understanding and appreciation for the lived experience in the research process. I say to researchers often that we leave much of the data on the cutting room floor because it doesn't fit a prescriptor. It's not direct. It's not those kind of things that you typically hear. We know that patients speak in stories and problems, not in direct, quotable, researchable research topics. They tell their story. And in the midst of their telling their stories, it behooves us to be able to help them understand how that is something that could be beneficially studied in research. And then we enhance the capacity of patients as a fully vested research team member to ensure receive study sensitive data and to have the needs resources to respond to emerging critical issues. Long and short of it is keeping our patient partners in the loop. What's going on with the study? What challenges are they facing? Even if it doesn't feel like it's something that should be, that patients may be able to address, I would suggest that we definitely don't play that role short, that we be open and intentional in making sure that our partners are part of the team. And the next slide shares that the intentional planning. Remember, the issues and needs of patients are different than researchers who are often funded by to carry out this work or similar works. But patients need funding for being able to travel, for dissemination, to be able to attend conferences, to be able to be a representative of your study. And they need to be prepared for that and equipped for that, and then have the travel means by which to travel and makes sure that presence is felt. Increase time to understand the scientific documents, making sure there's someone there that's working with them to help them, break down some of the language barriers and understand what's the gist of this report, not just hand it to them and say, read this report, and think that in the end they will understand the scope of it. Setting time aside to review with partners is invaluable. A mentoring process, helping them to know that you're with them in this process. And training activities is the next slide that talks about the bidirectional training that's needed. Increased training for patient partners in an overall research process, helping patients understand the process from beginning to end once we find patients that are interested in participating. An opportunity for patients to participate in the planning and delivery of training for researchers and other stakeholders, sharing their ideas, sharing their experiences, and helping them to put language to their experiences and their feelings. Moving from now next slide, and we're getting close, this is it, is moving from passion to capacity. Passion does not seal the deal for meaningful engagement. We must move patients from subjects to participants to partners. And that is the continuum I strongly recommend in research and in decision-making process. With valued respect, power, with shared vision and goals, and with measurable outcomes and metrics. As a team, patient researchers and other stakeholders have the potential to deliver models of meaningful, sustainable, engaged research that has meaning both for the researcher, its institution, and the population that the research will eventually impact when it is implemented and carried out in clinical settings. So I thank you for allowing me to share my experience with you this morning, and I pass it back to David, and I apologize if I've taken too much of your time.
Not at all, Neely. Thank you again for sharing your perspective. And it's been such a wonderful opportunity to work with you on the BCORnet bariatric study and our subsequent work with BCORI. And I've learned so much from you about how central the patient role can be to the process of research across the whole spectrum from beginning to this point of dissemination. And it's really transformed the way that I do research across the board. So I want to thank you for that.
Thank you.
And I'm going to share my slides and
Hey,
bring up.
David,
Yes.
I apologize for interrupting. We're going to take a quick break to see if there's any questions for Neely before we jump into your stuff.
Let's do that. Yeah, thank you.
So there's two ways to participate. Feel free to either enter your question using the chat function, or if you'd like to ask your question live, please raise your hand. So I have a question. And I'm not sure if this is for you, Neely, or for David. How are patients selected, identified for these research projects? How are you contacted, Neely?
Well, again, I have been working in the field with other committees and working with our local CTSA. So when these different opportunities came up, the PI that was here in Nashville at that time informed me of those opportunities and asked me if I was willing to participate. And throughout the process, we have sought to find other individuals who were interested or able and willing to participate on different levels. So we've been brought in both as just by sharing the information and letting people know that there's an opportunity for you to work with folks around these issues of research.
Thank you. I think the patient voice is so valuable. So we do have one question from Carla Cowan. She says, hi, Neely, what barriers did you encounter in your participation in BCORnet?
Well, Carla, the typical ones was, not just being present, but being heard. One of the typical things that happens when we are in settings where the environment is not necessarily conducive for you to share your ideas is you tend to withhold them. You tend to sit back and listen to see what other folks have to say. But this topic was such a meaningful to me that I would risk, making a comment or asking a question, and I was well received. So whenever, we have that opportunity to receive folks from where at the level they are and be able to have that conversation as in an open format where there's no judgment, no like of, why are you wasting our time? We don't have time to answer these questions. It makes a difference. It just makes a world of difference. So I think that's the way we have to help patients become more involved, by awareness, allowing them to know that, making them aware that these opportunities are available, and then capture their interest in the work that we're doing.
Great. Thank you so much, Neely. We have a question from Michael Berry. Hi, Michael. Go ahead.
Hello. Neely, I really enjoyed your presentation and your comments.
Thank you.
Many of us working in the area of shared decision-making have been hoping that this might be an approach to at least help address some of the health inequities that are unfortunately so common in our country. And the evidence is pretty fragmentary thus far, but we look to results like David Arterburn's study of the effect of a hip and knee arthroplasty decision aids at group health, where patients are relatively well served, which seem to decrease rates. And when the same decision aid was used in clinics serving Black patients in the greater Philadelphia area who were traditionally underserved, they seem to increase rates. That's a suggestive finding. More needs to be done. But I'd be interested in just your perception of the potential for this approach to address health inequities.
I think that it is a wonderful opportunity for us to address health equities in this regard. I think the more information that people have about these different procedures and have honest conversations about what, the benefits and the risks, the more open we will find people to being able to step out and trust their provider and trust the information they are receiving. What is happening is we're getting so much information from so many different sources, and that can be in its own self problematic because it's not necessarily the correct information. So it's almost like we have to counterbalance some of this false information that's floating with real information, and decision aids can help folks to, compare and contrast and see what works for their life and their lifestyle.
Many thanks.
Mm-hmm.
Great. Thank you, Michael. Thank you, Neely. So Neely, the next question is from, sorry, Vandana, I'm going to say your name wrong. Her question is, how do you think social determinants of health should be incorporated into the shared decision-making process, especially around barriers to engage and build trust with patients in a cultural, competent way?
Well, certainly that's something I think that has to happen. The social determinants factors are so prevalent, and they have to be considered in the context of the experience of the patient, I think. And so I think that we will have to, dig a little deeper, go a little further in being able to assess the needs of those persons who are impacted by the social determinants of health, and see how can we develop tools that will be more impactful for their process. We talk about communities of folks who are traumas on multi-levels. So when we look at the different components of the social determinants of health that impact a particular group of people, we have to recognize that it's just not an issue or one thing that can just go ahead and fix this problem and it'll all be fixed. They all are generated problems on top of problems, or problems that are byproducts of other problems. And so it's almost an unweaving of that circumstance, those circumstances, but not leaving folks in tatters, but leaving them empowered to make better decisions and to be able to use this information rather than now this information just be used on them and collect them into different groups.
Great.
And I'm so grateful we got so many wonderful people who are now saying, how do we capture this? How do we look at these social determinants of health in a different way so that we can be more equitable in the way we approach healthcare?
Absolutely. So Neely, I'm going to read a comment and then we have one last question.
Okay.
So the comment is, Neely, I can so relate to your comment that, quote, patients speak in stories. I have worked in healthcare for 30 years and I've never heard this articulated so clearly. Thank you.
Thank you for that comment. Yeah, absolutely. I mean, that's the way we communicate, and that is it behooves us to understand that so that we can better capture what they're saying, what's being said, and that even helps to build a trust. That helps to build confidence in the person. That, oh, I was heard. So it's really good if we could just equip ourselves to a new way of thinking, a way of thinking that matches the people that we're trying to communicate with.
Absolutely. So one last question before we transition to David. Karen American asks, Neely, what is your approach when you encounter a clinician that does not treat you as a partner?
Wow. Well, I actually have a personal story that reflects that. And the long and short of it is I really had to move on to a new provider. But there is a challenge sometimes, and there was a challenge for me. For my provider, who had been treating me for several years as an African-American obese 50-something-year-old woman, to this perspective of an African-American woman who had gained new skills and was seeking to prevent health issues. And so my final statement between myself and that clinician was, she said to me, when you get sick, I will treat you. And that just didn't sit well with me because I was trying not to get sick, but it seemed that there had been a thought process that these are the steps that's going to happen to you. You know, you're obese, you're under a lot of stress, you're overworked, and you go and you know, and these things are going to compile upon you. So sooner or later you'll have a stroke, maybe a heart attack, or you'll do this or you do that, and then this is your life trajectory. When you throw in a serious attempt to change the way you live, to change the way you think about food, to change the way you process your thoughts, it doesn't always fit with everyone. So you have to be able to just share with people where they are and move to those people who have a broader sense and I hope now that provider has had enough patients who have changed their lives that she is able to be a better provider in that regard. But as for me, it was just time for me to move to a new provider who could understand where I was in my process on my life journey.
Thank you for that. So as we transition to David, so appreciate your comments, Neely. One more comment. Van says, thank you, Neely. Totally agree with your comments around SDOH factors. Thank you for being a shining beacon in this area.
Thank you. Thank you all so much.
Thank you. All right, David, go ahead.
Thank you all. So now I'm going to talk briefly about what we found from the PCORNet bariatric study that Neely helped us to conduct. And I partnered with Kathleen McTighe from University of Pittsburgh Medical Center. Neely, Kathleen, and I were co-principal investigators on behalf of a large group of the PCORNet Bariatric Study Collaborative, was funded by PCORI. So how was this study different? So we've heard that we had a patient co-PI. We actually had another patient involved in our study team as a co-investigator. And then we had a stakeholder advisory group that was convened regularly with patients, advocacy group members, adult and pediatric surgeons, and obesity medicine providers that helped identify the different outcomes that we should address, prioritize different analyses, advise on our study design, and plan our dissemination of findings. This was a large study involving 41 different health systems from 11 different networks within the PCORNet bariatric PCORNet network. For our main outcomes for weight loss, we had over 46,000 adults from those 41 health systems that had bariatric surgery. Most of them had the gastric bypass or the Roux-en-Y RYGB. 41% had the sleeve, which is the SG procedure, and 6% had a band or AGB procedure. The mean age was about 46, and as typical for this population, about 80% of the population was female, but we had a lot of diversity with 21% Hispanic and 21% African-American patients. The mean BMI was in the upper 40s, with over a third of patients having a BMI over 50, and a hypertension, diabetes, high cholesterol, and other chronic health problems were very common in this population of patients. And the patients who had a bypass procedure had higher BMI and more comorbid conditions than those that had the sleeve and the band. When we looked across the 11 different networks, we found that there was wide variation in the types of bariatric procedures that were being done. For example, a couple of the networks, almost all the patients were getting the sleeve gastrectomy, versus in other networks, most of the patients or almost all the patients were getting the bypass, which just showed the large level of variation in clinical practice around the time of the PCORNet bariatric study. What we found in terms of weight loss is that these three different operations have very different impacts on weight, with the greatest amount of weight being with the bypass procedure, followed by the sleeve and then the band, and that continues over the long term out through 5 years of follow-up, with different amounts of weight regain, with the greatest amount of weight regain happening for the sleeve procedure. So clear differences in the impact on body weight, but also very big differences in the impact on diabetes. This plot shows the incidence of going into remission, where you come off all of your medications and have normal blood sugar. And what we found is that in the first year, the bypass and sleeve are very similar, about 59 and 56% had remission, versus a third of patients with the band. Out to 5 years, 86% of patients and 84% of patients in the bypass and sleeve had a remission event where they were off all medications and had normal blood sugar through at some point in the 5 years of follow-up, compared to only 59% for the band. And then also we found that the rate of redeveloping diabetes or having a diabetes relapse was very different. And through 5 years, we found that 72% of the band patients that had gone into remission relapsed their diabetes after 5 years, whereas only 42% of the sleeve and 33% of the bypass. So that the bypass patients did the best in terms of diabetes outcomes. And that's also illustrated in this graphic, which shows the change in the hemoglobin A1C level, the measure of blood sugar, over time. And you can see that there were pretty big differences clinically in the 3 different procedures, even out at 5 years, where the bypass patients' hemoglobin A1C improved the most and stayed down longer and was more durable over time. Also, we looked at the impact on adverse events, and we found big differences in these different procedures, where comparing in this first column, sleeve gastrectomy and gastric bypass head-to-head, the sleeve had lower rates of 30-day major adverse events, reoperation or endoscopy, and rehospitalization of all causes, but no difference in mortality. So the sleeve was safer than the bypass in that regard. When comparing the band and the bypass, the band was safer in terms of 30-day major adverse events, but in longer term had many more reoperations and hospitalizations than the bypass, with no difference in mortality. And the band, compared to the sleeve, had many fewer 30-day events, but had many more reoperations or endoscopies or rehospitalizations than the sleeve. So clear differences, and this points to a clear need for shared decision-making, and no one bariatric procedure is right for all patients. And the patients and physicians need to consider the complex trade-offs between the risks and the benefits of these procedures, where gastric bypass has potentially the best weight loss and improvement in diabetes outcomes. Sleeve gastrectomy had the lowest rate of reoperation and rehospitalization, and the band had lowest early risk, but higher long-term risks. So patients and providers really need help with these conversations, and that's where our work came in, where we then sought funding from PCORI and were successful in obtaining funding to help us support a shared decision-making, dissemination, and implementation project involving Kaiser Permanente and the University of Pittsburgh Medical Center, again with Dr. Kathleen McTighe and Anita Kirklis from University of Pittsburgh Medical Center and Dr. Neely Williams. So as a little bit of background here, we looked at the literature to see what is important to patients as they're considering bariatric surgery, and we found that some literature pointed to the fact that patients really want to know. This is a survey of some patients in the Netherlands about what information they wanted to know at the time of making a decision. What seemed to be most important to them are highlighted here in the blue arrows, where they wanted to know what their treatment options were, what the most common complications were, their individual risk of those complications, understand the different forms in treatment, in particular, the different effects on weight loss after their operation. But interestingly, some literature also points from qualitative studies that there is both some congruence, but also discrepancies between what patients and surgeons are thinking about when they're making these decisions or having these conversations. Surgeons tend to focus more on medical complications, absolute weight loss and reduction of comorbidities, but patients also prioritize information about quality of life outcomes and the ability to feel like they're having a normal life, feeling in control of their health and having total well-being. And some patients believe that it could provide a solution to more problems, including mental, emotional, and social well-being problems, and that alleviating emotional distress was a key factor in influencing their decision to seek surgery. So thinking about this whole picture of what patients really need to know as we move forward to try to improve shared decision-making. In our 2 health systems, we use something called the EPIS model to guide our implementation project, which EPIS stands for exploration, preparation, implementation, and sustainment. And where we're taking a look in the exploratory phase, which for us was really the grant writing phase and securing funding, talking to health system leaders within the different health systems as we were getting their buy-in to do this work. We looked at system level factors, organization level factors, provider level factors, and patient or client level factors in terms of their impact on this decision-making process. And then as you move into the preparatory phase, you form a multidisciplinary implementation resource team to help you digest all the barriers and challenges to doing shared decision-making well, and land with a shared decision-making approach that you move forward in the implementation phase that has ongoing check and adjust built into it with ad hoc adaptation to respond to the challenges of the implementation process, and then leading towards, we hope, improved patient outcomes in terms of our main interest was to see that patients had a change in their self-reported fidelity of shared decision-making or their experience with shared decision-making with their providers. But we also wanted to see documentation of shared decision-making in the electronic health record, use of decision aids, bariatric referrals, impact on treatment decisions, and also the impact on providers. So we formed 2 implementation teams, one at KP Washington and one at UPMC, along this EPIS model that include patients, surgeons, family medicine, and primary care providers, quality leaders. And we'll get to hear from Dr. Paul today, who's a primary care leader in family medicine for KP Washington, who has been one of our shared decision-making champions throughout this project. So Dr. Paul will be sharing her perspective shortly. But we also included surgeons and other experts in shared decision-making and implementation science, including Dr. Stillwell, who I saw was on joined us on the call today. So in looking at this process together, one of the first things we did was to identify barriers to shared decision-making. Both of the implementation teams underwent a process where we met and did some individual pre-work identifying barriers by these 4 different levels of system, society, organization, provider, and patient. And then we synthesized these, defined and collated these lists, and then ranked them and prioritized these barriers based on the degree of importance and on the feasibility of being able to address these barriers. And this set of graphics here from Mentimeter is a tool that we use to help us actually rank in real time the top barriers that were identified by our different implementation teams. And essentially what this shows is an axis of feasibility where up arrow is moving towards more feasible to address, and then left to right is moving from least to most important to address. And you can see that things that are up in the upper right quadrant here and moving further to the upper right are those that were both most feasible and most important to address. And so we selected those that sort of came up as the most important and most feasible to address in each of the health systems as those that were going to be prioritized in our implementation approach. Not that these other areas wouldn't also be important, as you can see, but some of them were less feasible. And so we left them as things to maybe address later. And this table just lists some data from a publication from 2023, where we highlight all of the learning from this nominal group process, where we identified the most important barriers. Lack of insurance coverage and lack of understanding about insurance coverage were key barriers across both health systems. Lack of organizational priorities, organizational prioritization of shared decision-making around bariatric surgery or shared decision-making more broadly. Lack of knowledge about bariatric surgery, both by providers or at the organizational level. Lack of departmental clarity around who does what in the shared decision-making process. And limited training on shared decision-making conversations and limited tools for bariatric surgery. And other topics that were also prioritized by individual health systems in this were lack of knowledge about other weight management resources, technical difficulties about adding things to electronic medical records to support shared decision-making, and concern about surgeons having strong preferences around procedure choice. So we thought about all of these priorities, and we developed strategies that addressed each of these barriers as we move forward. And the key strategies that we developed were some decision aids. As part of this project, we partnered with decision aid developers to create decision aids that helped us translate this PCORnet bariatric study evidence into plain language that patients could discuss with their providers. We then developed workflows to help clearly define roles and responsibilities to accomplish shared decision-making in both health systems in the different settings that we were working with: bariatric clinical settings, primary care, and also with diabetes care management nurses. We developed and hosted CME presentations to train these teams on workflows, on the decision aids, and on the shared decision-making tools. We identified patients who had coverage for bariatric surgery. We built Epic tools to help with decision aid delivery and with documentation of shared decision-making conversations. And then we built dashboards to help provide audit and feedback data to show progress towards decision aid delivery and documentation to the teams. But there were many challenges which began with the pandemic. We had originally hoped to launch our project in July 2020, but with the pandemic occurring, primary care was overwhelmed. At Kaiser Washington, the primary care team said, we can't engage in this at this time. And so we switched to move to work with our diabetes care managers, nurses, care managers who do chronic disease management for patients with diabetes as an alternative to working with primary care in the KP Washington side. Elective surgery at both health systems were canceled for periods of time, off and on throughout the pandemic. Clinical budgets were really impacted, and that had an impact on even our decision aid vendors. And there was a change in our decision aid vendors in the middle of the project where we had to then switch to another vendor and develop a new decision aid with a different vendor in order to deliver this information to patients. And so all in all, we had about 18 months of delays and ended up launching in January 2022. We ended up working with EBSCO Option Grids and their health decisions, Dynamed health decision aids, and we developed two different decision aids, one more generic for a sort of a primary care discussion about weight loss surgery, and a second for a discussion with a surgeon where you would compare different operations head to head around different clinical characteristics that are important to patients. And this is just a slide showing a short summary of the kinds of information that was in there about the different things that patients might ask about weight loss, about the impact on diabetes on short and long-term outcomes. And you can see where this directly is informed by the data from the PCORnet bariatric study, as well as other research in the field. And then we developed these clinical workflows for bariatric programs, as well as primary care and also diabetes nurses. Here's the bariatric workflow for Kaiser Washington, where we had the placing a referral order, and there's usually a provider seminar that happens after a referral happens. And we introduced new information in the provider seminar to discuss these option grid decision aids so that when patients first hear about their different treatment options, they're being told about these option grids and how to access them, to think about them. And then during their initial visit with either the surgeons or physician assistants, we train the surgeons and PAs to have this shared decision-making conversation using 6 steps model of shared decision-making, using the decision aid, and then documenting that they had a conversation with their note template. And then the surgeon's pre-op visit, we also had them reconfirm the shared decision-making conversation and document that. With our diabetes nurses, they're seeing patients who have diabetes in a chronic disease management situation. And what we did there is we worked with medical assistants to flag patients who were both eligible for bariatric surgery based on their clinical characteristics, as well as having insurance coverage, so that the diabetes nurses would know who would be the best patients to have a conversation with. And then when they had their clinical conversations with them about their patients, they would review their patients' clinical conditions to make sure there weren't any reasons to think they might want to delay any conversation about bariatric surgery, such as new diagnosis of diabetes, starting insulin, or having a new mental health problem in the last 6 months. And then when they felt the time was right, they would introduce this decision aid and this topic to the patient as a treatment option for their diabetes, and then have a follow-up conversation to document that they had a conversation about this and whether or not the patient was interested in learning more and placing a referral order if appropriate. And we used 2 different models actually in this project of communicating where we use the 6 steps of shared decision-making at Kaiser Washington, because that is what we had historically trained a lot of providers on. And these are the 6 steps here on the left about inviting participation, presenting options, providing benefits and risk, eliciting preferences, facilitating decision-making, and implementing decisions. And we gave the providers these cheat sheets with some scripted examples of how they could communicate about these different steps with their patients, specific to bariatric surgery. And then at the UPMC, we decided to switch to a 3-talk model, which has team talk, option talk, and decision talk as the core cornerstones of that approach. And we, again, provided scripted text to help providers actually implement this type of model approach by giving them examples of how to do that conversation. So as we are moving forward, actually, somehow I jumped ahead there, apologies. Let me back up. So let me share some process and outcome measures. So far, this is focusing on Kaiser Permanente data. On the left-hand graph, you see the bar shows the number of patients that had initial visit with our bariatric program team month to month over the course since implementation. And the line shows the percent of patients who had EPIC documentation of shared decision-making. So you can see initially about 50% of our visits were getting documented, and we have jumped up to better than 80% around for most of the time period, although there's been some variability in time of the PAs and surgeons documenting at that initial visit. On the right-hand figure shows the preoperative appointments, and you can see those are all done by our surgeons, and they've done an excellent job. Nearly 100% of patients across the board having documentation of a shared decision-making conversation with their pre-op visit. This graph shows on the left the proportion of patients having documentation of shared decision-making with EPIC using a decision aid in EPIC over time in relationship to the total number of patients who had a bariatric operation. And you can see that we started off, back in February 2022 and slowly but steadily increased and have been doing a fantastic job with all of our patients in the last 6 months having documentation of shared decision-making in the electronic health record prior to having their bariatric operation. And that's a huge effort on the part of the surgeons and PAs to make that happen. And this graph on the right just shows the proportion of patients that are having bypass or sleeve month to month over the course of the study period so far, where towards the beginning of the period, it actually looks like we were doing slightly more bypass operations than sleeve. And as we get a little further on, it's beginning to start to look like there's at least as many sleeves as bypass, and in some cases, more sleeves than bypasses. So it'll be interesting to see as we do a trend analysis what impact or what the trend has been towards the types of operations that are being done. For our diabetes nurses, this first graph on the left just shows a trend line of the number of conversations that were being documented by our diabetes nurses by month. And you can see that over time, they've generally been increasing their number of conversations that they're documenting with their patients with chronic disease management for their diabetes. And on the right, we show that in the bottom of part of the bar, the dark part of the bar is the number of closed shared decision-making conversations versus the top is deferred shared decision-making conversations. So in this chronic disease management setting, some conversations are being deferred, whereas others are being closed. And I want to just touch on our outcomes briefly, which is our primary outcome is being collected by a patient-reported survey of their experience with shared decision-making at 3 different time points. We're surveying patients who have at the referral time point, the initial visit with the surgeon, and then the preoperative visit. And we're using 3 different measures of shared decision-making to capture patient experience, the Collaborate, the SDM-Q9, and the National Quality Forum measure. So far, we only have completed data collection at baseline. So what I'm going to be describing is the baseline data. We included any patient referred to our programs that were adults who had not previously had surgery, and we have a total of 75 patients from each health system that were included in this survey, 25 for each of the 3 cohorts I was mentioning. And we're doing our follow-up survey actually beginning this week, and we're going to be fielding that through July. But these are our baseline results. which if you focus in on the collaborate row here, this is our primary outcome. And what you see here is in bold is the percent of patients who gave the provider the top score on doing shared decision-making at the time of referral. So they're referring back to whoever had referred them. So that's probably their primary care provider, but could have been a specialty care provider that was referring them, like a diabetes nurse. And you can see that 53% of patients were giving their providers the top score. Over time, you see as we move to the initial visit with the bariatric program, 60% were getting a top score. And then later in the third cohort, the pre-op cohort, 70% were getting the top score. So the good news is that as we move forward in time, the scores seem to be improving in terms of the closer they get to surgery, more providers getting the top score on shared decision-making. When we look at these other measures, the bolds represent mean values on these, where higher numbers indicate better shared decision-making. And the scale for SDMQ9 is 0 to 100. So 100 being the best possible shared decision-making. And again, you see that it's getting better over time for that particular measure. The NQF measure of shared decision-making, it definitely improved from referrals to initial visit, but no difference between initial visit and pre-op in terms of the score. So it's interesting that these different measures provide somewhat different information about the patient experience, but in general, it seems like as they get closer to their surgery date, their ratings of shared decision-making have improved. So we'll be interested to see what impact all of this work of implementation has had on patient experience with shared decision-making. We're currently finalizing our dashboards with KP Washington and with UPMC and rolling those out with providers further. We're fielding our survey, as I mentioned. We're also going to be conducting qualitative interviews with providers and doing a qualitative data analysis. And then our quantitative data analysis will be capturing these trends in decision-made delivery, documentation of shared decision-making, referrals, pre versus post implementation for bariatric surgery, the rate of surgery out of those who are eligible, and the choice of bariatric operation. So bypass versus sleeve versus band. And that is everything that I wanted to cover today. I just want to thank you again for the opportunity to present. I don't know if we'll have time now to answer any questions. Happy to do that. And then we can hear from Dr. Paul.
Yes, thank you, David. Very, very interesting work that you're doing. We do have one question in the chat. Karen asks, she says the EPIS framework looks widely adaptable to different implementation efforts. Is this a primarily clinical framework, or is it used more broadly?
That is a great question. I wish one of our implementation scientists from the team was here to answer that. I have only focused on it in the clinical perspective, but I do think you're right that it could be adapted to settings outside of clinical practice. This idea of looking at these different levels of influence, the societal level, local level, individual level, could be adapted. And I think this idea of forming multidisciplinary teams focused on implementation makes a lot of sense as well, where you get diverse voices, perspectives brought together. And then, having an implementation and check and adjust and sustainment metrics that you're particularly tracking does make sense to me, that this could work in a variety of settings. I think it's most often been used clinically. Thank you, Karen.
Great, thank you, David. As a reminder, please feel free to put your questions in the chat, or if you would like to ask your question live, please raise your hand. I should have mentioned it before. You can find that function under reactions, or you can just unmute yourself and ask your question now. Ryan, do you have a question?
Yeah, absolutely. Thanks so much, Dr. Attenborough. It's a wonderful presentation. Just a quick little background. I'm one of the implementation scientists through Periop Surgical Services in Nova Scotia and work for Nova Scotia Health Authority there. I've had about a decade of work with one of the cardiac surgeons at the hospital trying to implement shared decision-making in cardiac surgery, but also other surgical specialties. And there's been some uptake. Sometimes it's this slow push of trying to remind, trying to kind of encourage, and trying to get the carrots of what the benefits are of shared decision making. And I think the EPIS guideline was really wonderfully presented today. That just sort of gives some contextualization towards some of the motivation, some of the ways that, you know, the barriers, facilitators, how to sort of focus on that content. I guess my question, of which I certainly have many, but in terms of what seemed to be rocky road with decision aid vendors, some of the EMR issues, how realistic is it to, we have a small research team where we've developed these things in-house, and they, you know, in order to kind of create a decision aid for someone, that's used to be me printing one off and then giving it to our nurse navigator. That would be taken to the patient. So I'm wondering if you have any sort of insight towards the benefits of doing some of this work in-house, where you're maybe less dependent on outside vendors, versus what sounds like the scalability of being able to do this stuff so that you can push it out to more people. So I'm not sure if I've articulated that too well, but certainly welcome your thoughts there.
It's a really timely, important question. Dr. Paul will share some more about our journey around vendors in a bit, and I think you'll be interested in hearing that conversation. I think, you know, we're also debating this frequently around different topics. I think that it's, you know, a lot of work to maintain the tools. So this is the biggest challenge in terms of keeping them up to date if you're going to grow them yourself and develop them yourself, and to make sure that they're high quality. So this is a real challenge, but I think, you know, if you have the right team and people that are committed to the time and effort required, it certainly can be done. Kaiser Permanente puts a lot of effort into clinical guideline review on a periodic basis for various topics, which is very similar to the review process that we undertake for developing decision aids, of evaluating the literature and making recommendations about different treatment options. So I think there are some ways that you could have some economies of scale if you kept guideline, clinical review, and decision aid development sort of married and within the same organization, that you could accomplish this on your own. But there's something really appealing about working with vendors who are going to handle all this across a large number of topics. But there's also a number of challenges. Dr. Paul will touch on those some more later. Yeah.
Thank you.
See a question from
one more
from
question.
Karen.
Sorry, David. One more question, then we'll transition to Katie. Has the emergence of blockbuster, quote, weight loss drugs affected surgical rates for shared decision-making content or processes for weight loss?
Great questions. So the newest blockbuster drug, of course, was just introduced in 2022, and we don't have good national data yet on what impact sort of that has had on the volume of surgery. So I can't really say, but I think it's probably going to have a significant impact over time. I don't think surgery's going away. I do think that it'll be a staged care approach, and also some patients who get surgery will also get medications to help them maintain their weight long term. So I think it's going to be a both and kind of adjunctive treatment scenario. But I do think that these weight loss drugs are a really important tool, and going forward, integrating them into our shared decision-making process is going to be really important. I know that vendors are already beginning to develop tools around them.
Great, thank you, David. Any last questions before we transition? All right, I'm going to turn it over to Dr. Katie Paul.
Hi, everyone, and thank you for having me today. I will do a very, very brief introduction. In short, someone introduced me in the interim or in the beginning. I am a family doctor at Kaiser Capitol Hill Clinic in Seattle. I also teach in our family medicine residency, focusing on evidence-based medicine and quality improvement, which includes shared decision-making teaching. And then I work with David through our quality department. So I oversee many of our clinical publications, clinical guidelines, and some of our online content for providers. And that's kind of how I got involved in shared decision-making work several years ago. So I want to tell you a little bit of a story today about the shared decision-making journey at Group Health, or now Kaiser Washington. And some of you are very familiar with this, but I want to start kind of at the beginning of our journey more than 10 years ago, when we had kind of an online version of HealthWise shared decision-making tools or decision aids about things like hip and knee joint replacement. So I think at the time we thought we were doing shared decision making by giving patients handouts on this content that talked about, what is arthritis and what are your options in treating it, and should I have surgery? And this was really the beginning, but it generated this movement towards thinking about shared decision making as not just something that's nice to do if you have time. Like, yes, it's this great thing, and yes, we should do it, but if we have time, if we have the right resources, et cetera, we really kind of started this cultural shift, or at Group Health at the time, going through this cultural shift towards the idea that this is a required part of pre-surgical planning, particularly for surgeries, for some non-surgical conditions as well, but that no patient should undergo a procedure or surgery for a preference-sensitive condition without having a shared decision-making conversation documented. We want that to be the standard, not just this nice thing you do if you have time. So that work, came out of several studies that, David and many of his colleagues were involved in at what was then the Group Health Center for Health Studies, when evidence started to show that using video-based decision aids or other decision aids really improved patient satisfaction, patient knowledge, et cetera. And as people have talked about earlier today, in some of the studies, it did also reduce surgical rates. But I want to be clear that that wasn't actually the goal. We wanted to make sure that patients had the right information to make the best decision for them. And so there was increasing evidence that decision aids were one way to get there. So we started working with a vendor, Health Dialogue at the time, that made video-based decision aids. We had 12 topics you can see here. They're pretty long videos, something like 40 to 50 minutes for most of them, but on key preference-sensitive, mostly surgical topics. And the idea was that before referring a patient for one of these procedures, or when someone was counseling about whether a patient wanted a procedure, whether that was their primary care doctor before referring or a surgeon in a pre-op visit, that a patient should have access to one of these videos if it was relevant to them. So you can see this was one of our old websites. You can see you could actually watch the video online in later years, but originally it was a video. It was a list of videos or DVDs that we could actually mail to a patient. So when I started at Group Health in 2012, this is kind of what our Epic looked like, our EMR, and I could order any of these topics as a DVD, and it would literally be mailed to someone's house. I know that sounds funny now, but at the time, lots of people had DVD players. And so we could also track it because it was orderable in Epic. So we could see easily, did someone get a decision aid or video before they had surgery? We also at the same time implemented some IT tools to help providers, remind providers to send these. So for example, if I was sending a patient to orthopedics for knee pain to talk about knee replacement, the referral actually prompted me to place that DVD order at the same time. So in this slide, you can see monthly distribution of some of these shared decision-making videos. So this is all of them aggregated, all the topics. We did increase from 12 topics over time up to about 20 topics. You can see, where they were ordered. So patients could actually order these on their own via our website. If they looked at our shared decision-making site and identified that a topic was relevant to them, they could self-order. They could call our resource line, or a provider could order them. Those that are marked pre-visit are the sort of prep for surgical visits, typically in our orthopedics department. But you can see, on average by month, in the late 2000s to early 2012-ish, or 2010, I think is when this ends, I'm sorry. We were sending out 800 to 900 videos total per month on all of those topics. We also looked at an in-process measure, a defect measure, or sometimes we called it a miss rate. So essentially, how often did a patient go to surgery for one of these specific preference-sensitive conditions, and we had not documented shared decision-making? And by documented in this sense, it's a little bit different than what Dr. Arterburn was talking about with the recent PCORI study. We were just looking at, did they get a DVD or video? We of course don't know if they necessarily watched the whole thing or what the quality of the shared decision-making conversation was with their provider. But you can see over time, the blue line kind of decreasing, meaning we had fewer misses over time. By the end of 2012, most patients were getting a decision aid before surgery. So, and I think someone already mentioned this study by Dr. Arterburn and colleagues that showed that for hip and knee replacement surgeries, when patients did get a decision aid prior to surgery, it reduced the surgical rate 26% for hips and 38% for knee replacement, and did reduce costs. Again, that wasn't really ever the primary goal. We wanted the right patients to get the right surgery at the right time. But this was pretty profound in terms of really solidifying that culture at group health. And patients seemed to like it too. Most patients reported that the decision aid videos helped them understand their treatment choices and help them prepare to talk to their providers. So, there was a lot of energy around this. I said when I joined in 2012 as a resident, this was just the way we did things at group health. It wasn't this new fancy shiny thing. It was just part of our standard work in primary care. When I referred someone to a specialist, potentially for a surgical procedure, the teaching was you send the shared decision-making aid and you start that conversation. There was very high institutional support. That was the expectation that primary care would do this work before sending a referral or at the same time. And the use was pretty steady over these years. We got additional topics over time, and we got some integrated kind of homegrown tools that were not from the same vendor. We built a tool for making the statin decision, an aspirin decision for ASCVD primary prevention. That's a slightly different type of decision aid in that it's more of a visual icon array that shows a patient their personalized risk with or without treatment. And that one also became very popular and very widely used. And again, was just kind of part of the culture of this is how we do shared decision making at group health. And then of course, and I was also going to mention that we did require at the time, I think in 2016, all providers were required to do a shared decision making training. So that was expected of everyone as part of compliance training for that year. And then of course, what happens after that, right? We had high institutional support, high uptake. It was part of our culture. And then we kind of lost momentum. And this happens, of course, with lots of quality improvement projects. We think we're doing well. We think we have a great process in place. And then over time, that gets eroded. So there was a decreased institutional focus on shared decision making. I don't think that's that anyone didn't value it. It's just that I think we kind of thought we had it solved. I think we thought we were doing the work and it would just maintain itself. We also had pretty high surgical provider turnover and high primary care turnover. So all the people who got that SDM training and most of the leaders who were in place at the time of kind of the initial cultural shift were in other roles or gone. And then the last thing, the kicker, was kind of that we lost the ability to track. So we all know we can't measure, or you can't track what you can't measure, right? So what happened? We were up at 8,000 decision aids per year in 2014, and you can see that drop pretty precipitously over the next several years. And by 2020, it was under 1,000 videos over the course of the year. Now that was, of course, highly affected by the pandemic. We weren't seeing patients in person. We weren't doing elective surgeries. And also in mid-2020, that is when the metric kind of finally broke for good, and we really couldn't get any meaningful data from our EMR about video usage. So I said, you can't fix what you can't measure. We weren't really prioritizing it at that point. Every meeting that I went to was something along the lines of, well, the metric is broken and we need to fix it, but we're not sure when we can fix it because we don't really have any IT support for this. And then our contract with Health Dialogue was up in 2021. And so we needed to make a decision if we were going to continue with the video-based decision aids or switch vendors. And Health Dialogue became pretty cost prohibitive, unfortunately. We had good funding for this in the past, and when uptake was high, it made sense to continue that. But when we were sending a relatively small number of DVDs per month, it was a very high cost per DVD, something along the lines of $400 that we were paying per DVD. Part of that was that the vendor was requiring kind of a minimum order. And of course, by 2021, most patients were not using DVDs. Most patients were watching the videos online. So we literally had this backlog of thousands of DVDs that weren't getting used, and we couldn't track whether people were watching the online ones in any way. So we decided to think about a new vendor and started looking. And the way the structure is at this point, this was Kaiser. The contract for shared decision-making vendor is owned by the health plan, not the medical group. So the health plan kind of negotiates and decides on budget and decides on which vendor we can go with. And I'll also note that one challenge with videos, even though they are really, really great at selling those patient stories and talking about what the patient experience might be like, they're very long. And we found that people probably were not watching the entire video. We know providers were not watching the entire videos. We know providers didn't know exactly what the content was, and they're very hard to update. So for all those reasons, we started thinking about a new vendor. And we wanted something that was integrated into the EMR. We want something that we could use ideally in the room with the patient if possible. So in 2021, we chose EBSCO and their Dynamed Decisions product as a new vendor. And David showed the versions of the two weight loss related patient decision aids. Those were developed specifically between David's team and the vendor. So those were new for them. And they got to kind of really work on the content from the ground up. For many of their other decision aids, they already had content in place. But part of why we chose them was that their tools could be fully integrated into our EMR. We use Epic. And they sold us essentially 3 products as a package. The option grids, like David showed, for weight loss surgery, that are kind of these table formats. They're static, they're for specific conditions, but they help patients compare 2 to 5 different treatment options. And then they also have some personalized decision aids that use visual icon arrays, and I'll show you examples of both of those. They also included some clinical calculators. Those were sort of less critical for us, but they were kind of part of the package. And then they offered us the ability to track decision aid usage at the patient level. So we wanted to have good quality data on how many of these are we using and which patients are using them. So again, we want to be able to tell that miss rate. How many patients are going to surgery for these preference sensitive conditions without having been given a decision aid. So this is a screenshot of what the Dynamed Decisions window looks like within Epic. So it essentially opens in the Epic integrated browser for any of you who have used that before, and has this landing page. And we customized ours a little bit to highlight the most commonly used tools, including the bariatric surgery decision aids. But you can see, you can search, or you can look under the Our Tools for different specific topics. They have a total of about 60 option grids. So there are many, many more options than we had with Health Dialogue. And this is a picture of one of the option grids for hip osteoarthritis. So I think David showed the 2 for weight loss surgery. But you can see it's essentially a grid or a table, and you can X out any options that don't apply to a specific patient. So let's say I have a patient who can't take NSAIDs or has already tried PT. I can sort of get rid of those options in the table, and then I can print this. I can create a link, a customized link, and then put it in their after visit summary or send it to them online. There's a QR code. So if the patient is in the room with you and they have their phone, they can scan the QR code and get to the website on their phone. Lots of different ways that we can do this. And then the second type of tool I mentioned is this more customized or individualized tool. So this is an osteoporosis bisphosphonate tool offered by Dynamed. There are various other ones that are available online, but essentially it pulls data from Epic. In this case, it's not really, in our system at least, it's not able to pull T-scores or FRAX scores directly. although depending on the EMR, it does have that capability. But essentially, it pulls in things like age and sex and some other risk factors, and then the provider can customize those and add T-scores or other relevant data to calculate that FRAC score. And then it gives you a picture of sort of what happens with or without bisphosphonate. In our version, it gives us a few other treatment options as well, and you can kind of toggle between them to show a patient visually what is your risk in this case of major fracture or hip fracture with or without taking a bisphosphonate. And the way that this tool works in Epic, it's a little more challenging to share. You can share an option grid version. There's no direct way as of yet to show the picture, the visual icon array, other than taking a screenshot and copying and pasting that into an after visit summary. But I found that these types of tools with visual icon arrays can be very powerful for patients and very useful in guiding a discussion. So getting to our implementation, this was late 2021, we chose EBSCO Dynamed Decisions. IT work, we were told it would be about 5 to 10 hours of work locally. So the idea is this is essentially an external website that is now hosted within our Epic instance. What we did not know at the time was that KP Washington was actually the first EMR integration for this company, for this product. So it turned out to be, not surprisingly, a lot more than 5 to 10 hours. And we did not really have a project manager or an IT lead on this. We were kind of using people who were willing to work on it when they had time. And so, of course, that took longer than expected, and our launch was delayed a little bit into mid-January. We also found that it wasn't quite as easy as we hoped to pull data from the EMR. So some data came in correctly, other data either wasn't pulled at all or wasn't accurate from Epic. So we had to do some more IT work to fix those things so that the tools would actually work correctly. You can imagine providers don't really like it if you have a tool that has 20 different data inputs and only 3 of them come in correctly. The whole point of an integrated tool, or one of the points, is that we want to make it easier for providers so they're not having to do those calculations or transfer patient risk factors manually. But we also want to make sure it's accurate so that they are getting the correct information to patients. And then one thing, again, we didn't really anticipate this would be a barrier, but when providers logged into that Dynamed Decisions page for the first time, they had to create an account and log in. And that was only the first time, but that in itself turned out to be a big barrier. They also had to check a box that said they were okay with EBSCO collecting data on their use of tools. And some providers were really not comfortable with that. The data is not linked to individual patients, but it is linked to providers. And so some providers did not want to do that under a login. And if you don't log in, you can still use the tools, but it is much more challenging and limited. And then the big thing was the workflow is different for providers. We really had to do a lot of education to teach people how to use these tools, because it was not just an order in Epic. The prior one I think I showed, you literally would just put in the Epic order entry field SDM or the topic that you were interested in, and you would find the DVD. And this is a different workflow requiring you to use a different window in Epic. And like I said, create that login and then just get familiar with what's there. And so there was a lot of education that was required. This is a brief list of the different types of education we did, starting before the rollout and then trying to kind of target key IT leaders. We have a group of IT champions who are providers who do additional IT training for their clinics directly. So we worked with that group. We worked obviously with the orthopedic surgery group, with whom we have another PCORI grant. David and his team worked with the bariatric surgery group. And then there were lots of time with me and a couple other people going to individual provider meetings, and lots of email communication. But of course, we all know, not everyone comes to the meetings, not everyone reads the emails. So there were a lot of people who just never really learned how to use this new tool. So what are the ongoing challenges at this point? It's been a little over a year with this new suite of tools. I would say uptake is still quite low. It is a lot lower than I would like. And part of that is that initial, some people just never started using it. And then for those people who did try it, the loading speed has been an issue. So this uses a kind of a new technology called FHIR to pull data from the EMR and an external website. And that has been much slower than anyone expected, I think. So initially, the main website, when you opened it in Epic, was taking 12 to 15 seconds to load, and then potentially another 10 seconds for an individual decision aid. And you can imagine if you're in the room with a patient and you have limited time, that is just much too long. That has improved quite a bit, but it's still slower than all the other functions in Epic. So there is waiting and watching the screen spin, and people don't like that. And so some people, I think, just got frustrated and stopped using the tools. It also is just more clicks. It's not an order in Epic. So again, it's a different workflow. It's more clicks to get to the right decision aid and then to get to a link or to print it for the patient. And we still have a few issues with the EMR data not being pulled in correctly. So in terms of usage, in 2022, we had about 5,400 uses of all the Dynamed decision tools. If you recall, at peak with the videos, they were in the 8,000 to 9,000 range. I think one year we had 10,000 uses. So we're still well below that. And only about half of those are actually directly from the EMR. So we have a couple ways of using this. So directly from Epic, which I showed you guys, but also we have what's called a clinical library website, which is an intranet website for providers where they can use any of these tools. Obviously, in that case, it does not pull data directly from Epic, but providers can use those anytime. And then patients can actually find these tools from our patient-facing website as well. So most of those uses that are outside the EMR, we can't break down and see who's using them. We don't know if it's a provider or a patient. We don't know if it's directly related to patient care. So essentially, we don't really count those as true uses. We think that if you access the Dynamed Decisions tool within Epic and you're within a given patient chart, that's probably more likely a meaningful use. So that number is around 2,400 over the course of 2022. And keep in mind, there are 60 plus tools. So there are many more tools or different topics than we had for the videos. When we look at it by provider, we find there are kind of super users, the bariatric surgeons, some of the orthopedic surgeons and nurse navigators, and a few primary care doctors. And the vast majority of providers only used a tool once and then never again over the course of 2022. And it's really hard to tell, again, what is a meaningful use. Even if you open a decision aid within Epic in a patient chart, if if our data suggests that you used it 10 times over the course of an hour, is that one use or is that 10 uses? The way we get data from the vendor, it counts as 10 uses, but I think, we could probably all agree that's probably one meaningful use, and it's hard to sort out exactly how to remove duplicates or figure out uses that are not actually linked to a specific patient. So this is just a screenshot of what our initial vendor data looked like. So you can see it's not super useful. It's not super intuitive. I have information about the time and date and which tool was used and the number of seconds that it was opened for. But again, a little hard to know what is meaningful there. I cut out the data about the user. We do get data about which provider or who used it essentially. And it's available not just to physicians, physician assistants, nurse practitioners, but also RNs, MAs, basically anyone who has Epic access can use this. So I can tell who used the tool. In this initial data set, I actually can't tell which patient it was used for at all. So you can see that makes it very challenging to sort out duplicates. So ongoing challenges, and I think we're almost to the end here. Essentially, we found that even more than the technical challenges, we didn't have good agreement about the clinical content in the decision aids. So the bariatric team had great agreement because they got to develop these tools with Dynamed. But for example, for our orthopedics department, for total hip and total knee replacement decision aids, our surgeons took issue with a lot of the content. Not that it was explicitly inaccurate, it just didn't necessarily reflect their own clinical expertise or their own, complication rates. And so if they found that they didn't agree with the content, and the vendor, of course, is able to change the content, but not necessarily quickly, but providers just decided they weren't going to use the tools if they didn't feel like they represented what the information they wanted to share with the patient. And Dr. Arterburn has already talked about the fact that he and Neely are involved in a PCORI grant related to bariatric surgery. You guys have heard a lot about that. But we still have a second PCORI grant looking at orthopedic total joint replacement. And we really needed metrics for that study on REACH, sort of how many patients who went on to have hip or knee replacement surgery had a decision aid given prior to surgery. And the metrics that we were given, unfortunately, really didn't allow us to figure that out, because there was no way in EPIC for me or anyone else to tell, was this decision aid given, unless it was explicitly documented in the text of a visit. But there was, again, nothing orderable. So we worked with the vendor extensively over the last year to try to get patient level decision aid information to see, okay, was patient A given a decision aid on total joint replacement before their surgery? And that proved more challenging, I think, than the vendor expected and than we expected. This is initially what I got when they got to a point where they said, okay, we have patient level data. This is what I got. Now, normally, of course, I wouldn't share any patient level data, but you can see that this is totally de-identified and encrypted. And it turns out nobody can encrypt it, right? This patient ID field that we were given does not seem to correspond to anything in our EMR. And the vendor tells us that they can't de-encrypt it because they didn't create the encryption for it. And our IT team says we can't encrypt it. So the patient level data that we're left with is, well, I can see if it's a unique number or ID, so I can sort out duplicates a little bit, but I still cannot go back and say, okay, did patient A actually get a shared decision-making tool or decision aid before they had their surgery? We have now gotten to a point where we can link it to an EMR, but that took several more months of IT work. So as of April, what is the current standard? I would say uptake remains quite low. The exception to that is our bariatric surgery decision aids. Our bariatric surgeons and our diabetic nurse navigators are still using these decision aids, and uptake in that group, as you saw from David's data, is very high. But we currently have just over 100 uses per month on average. And those are what I would call meaningful uses, meaning in the EMR, not me using it to check it, not some of our other testers, but those are other providers who are using it in the room with patients or via virtual visits. So uptake is still low. Ownership of shared decision-making within our institution is fairly complex. I mentioned that the contract is owned by the health plan. The work in terms of promoting shared decision-making and doing projects like some of these PCORI grants and partnering to teach providers shared decision-making is really more on the medical group and the research institute side. And so we all work together, but we sort of come at it from different perspectives. And we, historically have not really gotten to choose exactly our vendor from the medical group side. Although we are involved in those decisions, it is ultimately a health plan decision. And sometimes that comes down to cost or other factors. The orthopedics team of note has reverted to not even using the EMR version because they found it too challenging for providers to learn and do consistently. So they are using the printed version, and they essentially use the PDF printed out, have a stack of them in their exam rooms. And that works for the purpose of getting the decision aids to patients. Obviously, it's not currently trackable, so we don't have a way of knowing how many decision aids they're giving out or to which patients. So that is challenging. And now, like I said, we do have patient level metrics, but they're not in real time. I have to download a report after the fact and then link it from those de-identified or encrypted patient IDs to patient medical records and go back and look to see which patients got decision aids prior to surgery. So there's no way, if I'm in the room with a patient talking about, do they want to go see a surgeon about hip replacement, I cannot easily figure out, has someone already given them a decision aid? And similarly, when the surgeons or the appointing center is scheduling someone for a consult with a surgeon, they can't tell whether a patient has already been given the decision aid or not. So that's kind of where we are. And I mostly want to spend time focusing on questions, but few quick lessons learned. We thought, like I said, I think we thought we had this solved 10 years ago-ish. When I started, it seemed like a no-brainer that we're all going to do shared decision-making. We're going to use evidence-based tools. But really, over time, we've seen that that's a culture that has to be maintained. It sort of needs constant nourishment in terms of training for new providers. We've had a tremendous amount of turnover of people who weren't here 10 years ago or even 5 years ago, but also leadership support. And that's challenging, especially in a pandemic, right? Our leadership is very supportive of shared decision making, but given multiple competing priorities, it hasn't been at the top of the list in the past few years. And then EMR integration is, of course, very complicated and time consuming. And we thought it would yield some results and some opportunities that ultimately, as of yet, it hasn't really yielded, shall we say, in terms of better metrics and more information for patients. I would say what it has done is given us more options of how to send the decision aid in more formats. And that is really helpful for patients. And then, working closely with your contracting team, in this case, again, they are on the health plan side. So working to figure out in 2021, when we were looking at different vendors, I don't think we knew the right questions to ask or the detail of the questions to ask in terms of what needs to be in a contract and what a vendor can or cannot do for you. So I think that's a key lesson learned for me, at least. And thinking about what metrics you need, being detailed about that, really showing, literally writing out a dummy table of what are the metrics that you need for your institution, and can the vendor reliably supply those to you, and in what format will you get them? Thinking about all of that upfront if you know what you need. I know that is a challenge as well. So I think I will pause there and I will stop sharing and take any questions, but thank you all for your time and attention. I appreciate it. Laura, I think you're on mute if you're talking.
I am on mute. Thank you. Thank you, Katie. And thank you for that great presentation. As we start to transition to the open discussion, it looks like Michael Berry has a question. Michael, please go ahead.
A reflection and then a question. First, Katie, thanks for the presentation. And more importantly, I'm just blown away by now Kaiser Community Washington, but formerly Group Health, trying to get this to work over actually 30 years. So I was a co-author with Ed Wagner on that initial trial of the BPH shared decision-making program at Group Health, which is coming up on its 30th anniversary. And we were using interactive video discs from Sony if you thought Epic Online was hard to implement. But like you, we've thought that integration into the electronic records, so you don't have to go somewhere else to do this, was important. We have Epic, we use decision aids from another vendor, but face the same challenges. It is clumsy in Epic, and we need to work on that. I keep telling myself that when it gets as easy to educate people about their fateful decisions as to build them, we'll know we've gotten somewhere with our electronic records. But it raises the question of why does it have to be so hard? We've gotten past the conceptual thing that most people think it's a good idea, but the logistical challenges, particularly without some of the specific incentives, at least in the kind of fee-for-service world, that have made things like the review of systems and notes or robotic surgery disseminate so quickly without having to do all this hard work. And I don't know if you were any from folks from the team, and I should congratulate not just Kaiser Permanente Washington, but all of Washington State of trying to figure out how to make this happen. So it's mostly an admiration comment.
Yeah, thank you. And it does, I think, many of the things I talked about, of course, happened before my time. And I just want to recognize all of those individuals who contributed. And I think I mentioned in late 2000s, it really did feel like a culture shift. And that was a huge effort. That was not one person. That was not even a few people. It was a huge culture shift really in Washington State broadly that brought about shared decision making. I remember in medical school, sort of similar to when I learned about quote unquote evidence-based medicine, Similar with shared decision making, you think as a young new person in the field, you think, well, what was there before? Like, what were we doing before? It seems natural. It seems automatic. We should be doing this work. But then you realize you have to maintain that culture. It's not automatic, and not everyone was trained in that field. And so I think we need to maintain it and have the impetus and the energy around it, but also recognize the technical barriers and the logistics of actually implementing it are incredibly challenging.
Thank you, Katie. Before we transition to our next question, I wanted to remind people, feel free to take yourself off mute or raise your hand or put your question in the chat. We also want you to share your experience with shared decision-making, any barriers or facilitators you've experienced, and any other challenges or successes you have experienced personally or professionally. This is a time to share with our peers and to learn about what we're all doing. And so I'm going to turn it over to Ryan.
Oh, thank you. I think in terms of my many questions, thanks again for the presentation. This was really valuable, and I think shows some of the strengths of working through with EMRs, some of the natural difficulties with integration, and in some ways it's a little discouraging from my vantage point in Canada and Nova Scotia, where I always see Washington State and sort of more broadly, you guys are leagues ahead when it comes to implementing SDM in all the ways that you do. So to know, like we've seen in our EMRs, in our OPORs, one patient, one record, there's at least some mention of patient engagement and patient education tools, but there's no specific focus anywhere about the shared decision-making sort of context or decision aid specifically. And I'm really eager to push that discussion there, especially because we're sort of in this period where we're only now working out the details of who the OPOR vendor is, where that's going to look in the next 5 years. So I'm wondering, with the difficulties that you faced with the EMR and vendors to date, it seems like I don't know, I don't want to say like we're in that DVD phase where there needs to be the next jump in order to ensure that you don't necessarily create animosity with those that you need buy-in from, because I've certainly experienced that, where once that is gone, it's very difficult to get that back if there's some delays or issues. So what are the big pieces when it comes to like your Epic integration or other sort of EMR instances that need to happen in order for you to kind of jump through those difficulties that you've experienced? Is that too big of a question? Is that there's multiple factors, or is it one or two sort of key things that really the focal lens has to be pointed to say, unless we have this, then we're not going to move much further? Thanks again.
Right, a great question, and I think there's lots of questions embedded in there, but I will try to address. And David, I would love your perspective as well. But I think the big thing, thinking back on this most recent implementation in 2021 and moving forward, the big thing that I think I would do differently or have our team do differently is really try to plan ahead of time and get all stakeholders involved and make sure that we, number one, have a product or a vendor that is going to meet our needs, but kind of outline ahead of time much more proactively, what are our needs? What are the must-haves? How does the tool need to function within the EMR to make it worthwhile? And if it can't do that, not do the EMR implementation. Thinking more broadly, we are very likely to combine our Epic instance with another Kaiser region in the next few years. And so they currently don't have any integrated shared decision-making tools. But I think planning for that, we need to decide together, like years ahead of time, what are the basics of the tools that we want? Do we want them to be homegrown, meaning Kaiser build them nationally or locally? And we do have some options for that in a sort of large institution, but we also don't want to recreate the wheel on a lot of clinical content that then again has to be maintained. So there's a trade-off there. So we want to think, I'm planning 2 years ahead at this point. I need to work with teams in other Kaiser regions to figure out what are the basic necessities of a shared decision-making platform. what would it look like ideally in Epic? And then is that possible? Does that exist from a vendor right now? Or is that something that we need to build? And even if it does exist, can we afford it? That's another big reality right now. Maybe the perfect, set of tools exists, but it is cost prohibitive for most places. And, Kaiser has more resources than lots of places and lots of institutions. So I think it's that planning way ahead of time. This implementation, I feel like we didn't know what we didn't know. And now we know more of it. I'm sure we do not know all of it. But thinking about just the institutional support, the rollout, the education, but also is this tool, can this vendor meet our needs in its current form? And then I think being willing to say no if that doesn't meet our needs. If we have a tool or a vendor that really can't meet our needs, maybe not putting the effort and time and cost into implementing in the EMR until we get to that point.
Yeah, and I would love to add that in that identification of what the priorities are for the health system, the thing that I learned through this engagement process is, as you mentioned, Katie, bringing those stakeholders together early and talking about that. I think in particular, talking about what are the clinical topics, what are the clinical service lines or clinical specialties that are most important that we prioritize? What are the clinical decisions that we really need to have covered? And then look at those particular tools and talk with those particular specialties and say, do you agree that these are the most important topics for you for shared decision making? And that, does this look like a good topic? One of the things that we learned through the bariatric process is that we really wanted to engage primary care, but it's shared decision making around bariatric surgery is just not a high enough priority for them, given all the competing demands to really, get high on their radar of what they really have time and energy to focus on. And they kept saying, particularly with our colleagues at UPMC, the primary care providers have been giving us really candid feedback that's been very helpful around, we have other topics that we really need good shared decision-making tools on. Why are we focusing on bariatric surgery right now? So it's, I think really getting that stakeholder buy-in up front and prioritization of the tools and that match between the tools and the clinical topic and the specialty, and sort of knowing that, okay, this is a good match for us to push ahead.
Great, thank you, everyone. I wish we had more time for questions. I'm going to close us now. I want to thank all of you for participating today, and a special thank you to all of our speakers, David, Neely, Katie. I learned a lot today, and I do feel very fortunate to live in Washington State. I give a lot of the credit of this innovative shared decision-making to Kaiser. You guys are definitely leading the charge, and appreciate everybody joining us today. Before we go, I wanted to remind you of a few things. In our previous professional partnership with HealthWise, we developed an online shared decision-making skills course for providers. I know you all talked about training for providers, that's important. This is an interactive course for providers that helps them understand how to implement shared decision-making, how to do it, how to engage with patients. And we're very happy to note that we now have CMEs available for that. Here's a link to the training. It's 90 minutes, it's self-paced. You can turn it off, turn it on, come back. And in addition to that, we want to announce that we're gonna have our first, or should I say our second in-person shared decision-making workshop, which we originally started in 2020, but we all know what happened there. In winter 2024, it's most likely going to be in January, but we'll send more information out about that. But if you have any particular topics or proposed agenda items that you're really interested in learning about, please feel free to send those to us in the mailbox below. Lastly, want to remind folks that the recording and meeting materials will be posted on the link here. The slides are already there. I also put that link in the chat. And feel free to send us any additional questions that you may have for any of our speakers, and we'll be sure to get them there. And Lastly, there's a link on the bottom. This goes to our shared decision-making page where you can see our current list of certified patient decision aids. And again, thank you again, everyone. Love to hear about your journey and wish you all the best in continuing in your efforts. You all have a nice day.
Thank you.
Bye.
Thank you.
Thanks, everyone.